Hi, welcome to the course. My name is Fuad, and this video series will help you understand your reading material, assessment, and health professionals education. Now I'll point out to you in this series what's important, what's not so important. So let's go right to it.
Right, now we will have a look at this section, scoring the performance, that is in page 145. Okay, scoring means how do we rate the performance in the performance examinations in OSCE stations. Basically, there are two ways here. The discussion, we are talking about checklists and we are talking about rating scales. All right. So what are checklists? Checklists are statements or questions that can be scored dichotomously, done, not done. So you have this list there with the box, greeted, patient, exposed, affected area, and things like that. Okay, so either done or not done. It's done this, done this, done this, things like that. Okay, this is a checklist. Okay, and we have case specific checklists, right? Case specific checklists are checklists that are done to identify actions essential to a given clinical case. Okay, it needs to be the issue is any checklist needs to be done by a panel of content experts. Okay, they should be evidence-based and reflect best practice guidelines. Okay, you don't simply write anything. It needs to be vetted. It needs to be peer-reviewed, and raters must be trained. Okay, who handles the checklist? So in the literature, they mention that it can be by the faculty or by the expert, or it can be by the standardized patients. So it has mentioned. It was mentioned there, checklists of 12 to 15 items can be successfully or completed quite accurately by well-trained SPs. Okay. So checklists are suitable for candidates or for situations where you want to make sure they do certain things or they avoid certain things and things like that. But however, it seems that the more senior candidates are not very well assessed using checklists. So it says down in the page, can be used effectively with beginning learners. However, comprehensive checklists are not always appropriate for more advanced learners. Okay, because the checklist excludes the role of experience and expertise. Okay, that comes with if you have expert raters and they, from their experience, they know the quality of a performance by the candidates. So that experience cannot be captured by a checklist, because checklists are often done, not done. That's all, right? So for senior situations, for senior candidates, and where we want to capitalize on the expertise of the raters, then we go for rating scale. Okay, what are rating scales? I think we have discussed this before. Rating scales are where the instrument has a rate, a scale, a scale maybe from 5, 4, 3, 2, 1. This one is you can have a look at the box 9.2. right? They describe rating scales very well, and they talk about the anchors. Okay, how we anchor the scales, the ratings. So you talk about Likert scale item, and you talk about linear scale items or Likert type. And of course, if you remember, we have the bars, the behaviorally anchored rating scale item. So you can use any of these for rating performance in the performance assessment. And there's a nice so you look at this in box 9.2, right? And in box 9.3 there's a sample of a post-encounter patient note scoring rubric. So you can use a rubric for scoring performance in a performance assessment or an OSCE, right? So these are good examples. So please have a look at what we call as anchors and rubrics, and there's discussion, debate again going on. Checklist versus rating scales, which ones are better? But actually I think the approach taken in this book is better, that you use both, but you use checklists more on for the junior, for the beginning level, where you want to make sure they do certain things or not do certain things. But as you go to a more advanced situation, or when you want the expertise there, you go for a rating scale. So you use both. It's not either or. Okay. And it is mentioned at the end of this section about training of raters, which is very important. As you go higher up the Miller's pyramid, training becomes more and more important. Of course, in the lower levels, if you remember the nose level and the nose how, at the nose level maybe you talk about using objective questions, you use MCQs and things like that. So you do not have to train raters because there are no raters involved. Okay, but as you go higher up here, then you perhaps at this level you would use lecturers to score the essays. So now you have to train the raters how to use the rubrics and things like that. So as you go higher up, you go for OSCEs and things like that, then the rater training becomes more and more important, and is most important where at this level, the DAS level, where you depend entirely on observation and judgment from content experts, and therefore rater training is very important. What do we include in the rater training? We have talked about this ever since the chapter 7, where we talk about nose and nose how. So training would include PDT, performance dimension training, as well as FORT, frame of reference training, which sometimes we call as calibration. We have to familiarize them with the instruments. We have to calibrate them, standardize their point of views and things like that. And the last section talking about this is the pilot testing, where it suggests that we need to pilot any performance test items that we have before using it on candidates. That's the ideal situation, where we need to pilot our items first. Okay, now this section deals with the multiple station performance tests or performance examinations, which we have performance assessments, which we have been discussing so far. Now we do it multiple stations. We have multiple occasions of assessing performance, and this is the well-known OSCE, the objective, structured, clinical examination, the OSCE. All right. Now, to start off the OSCE and how it came about, if you can recall our discussion regarding case specificity. We discussed this specificity. It is specific. Okay, we discussed this sometime before, where when we said that in the universe of a student's competency, let's say his cognitive or his knowledge, right? So if you ask, it's nicely put there in the section. If you ask a student one situation where can he or she diagnose a patient, or can he or she manage a patient with acute appendicitis, now, and he does it really well, can we predict about his overall universe of competency? Can we predict that he has the ability to diagnose depression? Similarly, if someone can take good history and physical examination for a patient with chronic diabetes, does that mean that he can take good history and examination in someone with acute chest pain? No, it is found out that we cannot predict by that single instance, because performance in all questions are specific for that case. They are case specific. Therefore, we need to ask a lot of questions. We have to ask them to perform in a lot of situations before we get a rough idea, or we get a better idea of their universe, of their overall competency. That is the idea, or that is the importance of sampling, which is related to reliability. Okay, now to achieve this, partially as a response to the problems people are facing in the long case, Harden in 1975 suggested the OSCE, where patients, candidates have to assess or have to perform a series of performance assessments, okay, depending on the series. So you have right there multiple sampling, so you have increased the sampling, and in each station, if you have to have patients, all the patients in there are trained to respond in a standard way. So you have SPs inside, so you have standardized, okay, and so standardization. And in all of these stations, you use checklists or rating scales. So the rating now is more standardized, right? More standardized, more objective and structured. Okay, and that is and because all students will see all the patients, therefore there is comparability. So that is, in a nutshell, are the advantages of the OSCE, why it is called as the objective. Now you know why it's objective, because we use standardized patients, we use standardized scoring, and all students will see all patients, and the rater stays in one station, so all raters will rate all candidates, right? And they are structured, which adds again to the standardization. This is a clinical examination, so this is an OSCE, and that is why OSCEs have survived right until now. Okay, so this section talks about OSCE and introduces it and talks about the duration of an OSCE. So these are what we call as stations, right? And the students go from one station to the other in a rotation. So each station is about, that can be from 5 minutes to maybe 30 minutes, right? Depending. Okay, shorter stations if allow for testing of discrete skills. Longer stations can allow the assessment of complex tasks. Okay, and there's a nice case example there, box 9.4. Box 9.4, where it shows you the OSCE for the USMLE. Okay, now the discussion goes on in page 150. 150 talks about the scoring of an OSCE. Okay, now what is usually done, we consider each station as a unit or as a question or as an item. So this station happens to have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 stations. Okay, so 12 items. So hopefully these 12 items are designed properly to sample across all the competencies that's required for this particular level of exam. Okay, and it's rarely that we combine, let's say, communication from all the stations. We combine the communication skill scores into one score, then and decide whether the students need to pass communication as a whole or not. So we usually take the aggregate score from all the stations. Okay, can we decide that they have to pass station A? If they fail station A, then they fail the whole station. As mentioned in the book, that is a policy decision, meaning that it can be done, right? If a policy level decision, if the group of content experts decide that it is unthinkable that a student can fail this station, for example, ACG of acute myocardial infarction, they must pass this. If not, if they fail this, they fail the whole. Then perhaps if they decide so, that it can be done. Okay, standard setting for OSCEs, usually if you use NGOF or other methods in which we look at the item, then we decide on the passing mark. It can be done, but it has been criticized. Okay, usually for standard setting for OSCEs, we use the borderline group and contrasting groups standard setting method. I know that we have not discussed this in detail yet, so this is something that just for you to know at this moment. Okay, only to please note towards the end of the standard setting discussion, it says the case level cut scores can be aggregated across cases to provide a compensatory type standard for the whole test, meaning that you standard set this station after another one after the other, and after obtaining all the cut-off scores for all the stations, you get an aggregate. All right, so that is a compensatory passing strategy. Compensatory meaning this station can compensate for this station can compensate for this station, and so on and so forth. Right, but if you want a conjunctive standard, conjunctive meaning you must pass A in conjunction with B, in conjunction with C, so it cannot help each other. So conjunctive standards can be in a form that maybe a specific number, n stations must be passed. Alright, or two or more subscales must be passed. N subscales must pass, and things like that. So this is considered as the conjunctive approach to scoring OSCEs. Okay, so you can have compensatory approach or conjunctive approach. Right. And how about procedural skills? Procedural skills, again, you use the rating scale or a checklist scale, but if you especially if you make the checklist public and incorrect performance comprises a threat to patient safety, then you can insist a mastery approach, meaning that candidates must be able to do it perfectly. If not, they will if they drop or they omit or they do badly in one of the components, we can make the candidate fail the whole station. Okay, that is in terms of scoring in OSCEs. And last, in discussing OSCEs, the author mentioned about logistics. If you remember, one of the drawbacks of performance assessments is logistics, because especially if you use OSCE, we need space. So space limitations, space requirements, we need financial, because we want to pay the standardized patients and all those things. We want to pay for all the simulation equipments and things like that, and we need also a staff to consider or to help out during the running of the OSCE. So conducting an OSCE can be daunting, as mentioned there. We need to train, we need a lot of things to be done. So these are the considerations when we do performance assessment.